My name is Lorraine Joseph Condathil, and today I'll be giving you a presentation on valsartan or nitrosamine-induced nevus-associated cutaneous melanoma, the hidden truth. This presentation and the paper was done with my colleague Nicola Oliveira, Professor Cardoso, and Professor Georgi Chernov. Before going any further, I'd like to say that all authors declare no conflicting interest and that this research did not receive any financial support. The clinical case here that I'd like to present is of a 57-year-old male with Fitzpatrick phototype 2. The medical history with arterial hypertension diagnosed in 2010 and started on valsartan therapy. He had consulted a dermatologist when he noticed a change in shape of the size of a mole on the back that reported its appearance in the last few years, several years after the initiation of valsartan, between 2012 and 2013. No other comorbidities were reported. So the anamnestic data that we had received from this patient was that the patient was taking a valsartan of 160 milligrams per day from 2010 to 2016 with a formulation from two different pharmaceutical companies. The first formula was taken for about 2.5 years to 3 years. The second formula with the same dosage of 160 milligrams per day in 2013 until 2016. From 2016 to 2020, the patient switched to a combination formula from a third pharmaceutical company, valsartan 160 milligrams and hydrochlorothiazide of 25 milligrams. 3 years after the monotherapy with valsartan, the patient developed a mole on the back which grew with time in color and shape. In 2014, a primary operation was performed on the lesion with 1 mm surgical margin, and histopathology revealed a superficial spreading melanoma associated with an intradermal nevus at the base, with Breslow thickness of 1.95 millimeters, low degree of mitotic activity without regression, perineural invasion, or microstellates. 19 days after following the AJCC recommendation, the patient underwent re-excision of the primary operative wound with a surgical margin of 1.5 centimeters in all directions. The surgical removal of the lymph nodes was performed under general anesthesia. The post-operative histopathological and immunochemistry examination showed no evidence with the markers of residual lesions along with negative lymph node biopsy. Patient was then referred to the regional oncology dispensary for active monitoring. When the patient presented to us, it was in 2020, and he came in with the presentation of multiple dysplastic nevi after the initiation with valsartan 160 milligrams and hydrochlorothiazide of 25 milligram therapy. Here we see the image of the multiple dysplastic nevi in the trunk, as well as on his back. So here we describe a patient who developed a nevus and later nevus-associated cutaneous melanoma after initiation of valsartan 160 milligrams monotherapy. Later the patient continued with this valsartan and hydrochlorothiazide and developed multiple dysplastic nevi and visited our department. Of paramount importance in this case is the time of onset of the pigmented lesion relative to the start of the treatment with the ARBs. So sartan and cancer. While the role of sartan as antihypertensive drugs with potential carcinogenic effect is generally debated, a number of experimental data in recent years speak in favor of a pathogenetic determined link and not a mere association between sartan intake and subsequent development of a cutaneous melanoma. The data available so far on this topic shows a definite presence of angiotensin receptors in melanoma tissue, as well as the administration of sartan could potentiate metastasis of melanomas due to the reduced expression of the receptor. Here we see studies have shown that the role of angiotensin II type 2 receptors in the melanogenesis and the migration of cancerous cells. Migration, invasion, and metastasis is potentiated by deactivated receptors. So therefore we have no longer inhibition of the CAB1 pathway. This image ultimately shows this, that we have the inhibition of the CAB1 pathway and therefore migration as well as metastasis. The focus of experimental and multicentric studies in the field of dermatological science confirms the presence of angiotensin receptors in the skin and melanoma tissue and local regional metastasis, as well as a possible potentiation of metastasis in a pre-existing melanoma cell. Given the finding of investigation studies to date, we believe that there is a possible pathogenetic explanation for the development of melanoma related to administration of sartan as a monotherapy in the case of our presented, as well as a probable combination with the hydrochlorothiazide. In recent years, in vitro studies have raised concerns about the possible role of the receptor blockers as triggers of carcinogenesis in relation to cutaneous melanoma, precisely due to the presence of the receptor in nevi and melanoma tissue. In vivo case reports are also available and further suggest a possibility of developing melanoma after the administration of both sartan monotherapy and hydrochlorothiazide monotherapy, or a combination of a sartan and a hydrochlorothiazide. Both these studies do not contain information, however, about the possible role of nitrosamines. In 2010, a study of meta-analysis of randomized controlled trials suggests that ARBs are associated with moderate increased risk of new cancer diagnosis. A year later, the FDA published a meta-analysis of 31 randomized controlled trials comparing ARBs to other treatment, but found no evidence of an increased risk of incidence in new cancer as well as cancer-related deaths. In 2018 June, FDA had a huge pharmaceutical withdrawal where they had taken out major production of valsartan containing products because it detected the trace of NDMA in the active pharmaceutical ingredient of valsartan. So nitrosamines. Well, the contamination with nitrosamines in antihypertensive drugs are another issue that must be raised here. Nitrosamines are carcinogenic and play a probable role in the pathogenesis of melanomas and other malignant diseases. The presence of up to 3 carcinogens in the form of nitrosamines in one tablet of antihypertensive drugs, such as sartans, is an indisputable fact, but clearly established repeatedly and currently by the control authorities in the face of EMA. So there is still many information that's been silenced. Individuals' claim of patients with serious side effects varies from 2 million to about 1 million. The Bloomberg TV in 2018 collective action of the movement concerning the sartan even brought about 91 million. Or else Monsanto, now known as Bayer, legally indicted in 2019 for over $40 billion indirectly, $1 billion for each family member, plus 55 more additional single compensatory claims. Here we see minimal benefit to patients that has been maintained by FDA or EMA, meaning pharmaceutical companies have a guaranteed payment and an overall prosperity. Here we see a study that was presented formally by AAD, or the American Academy of Dermatology in Washington, which had a look at these drugs and showed a significant increased risk of melanoma that was determined by ARBs. In conclusion, we can say that these findings were severe and it had an association with malignant melanoma and non-melanoma skin diseases and cancers with the use of ARBs and thiazides. Here we see the study. If we look at ARBs and thiazides specifically, we see a 2-time fold in increase in melanomas. According to the data presented by the colleagues in AAD, there is a risk of developing melanoma after the use of sartan. This risk is between 24 and even more than 225%. None of the presented data comment on or exclude the important factor for the carcinogenesis, the nitrosamine contaminants, and or what is the exact cause or means by which carcinogenesis is triggered. So where do we look for answers? At this point, no one knew about the contamination. Clinical observation can also be looked into, as after the use of valsartan or sartans, there has been development of de novo nevi formation. These nevi have shown to have rapid transformation from initially benign moles to subsequent dysplastic nevi, and then thin intermediate melanomas, leading to further metastasis. So what were the next steps that were taken? So in March of 2021, EMA officially authorized the safe dose of nitrosamines in sartans, but no one still knows what is the safe dose. After the 2010 withdrawal and 6-month grace period to clean and safe check of the shelves, there has not yet been an external control to check whether the carcinogenic impurities still remain. What is the exact concentration of nitrosamines needed to get the adequate response from the patients? So Navis-associated melanomas, especially when they occur after the use of valsartan or sartans, could be considered as part of an already emerging mosaic of pro-oncogenic actions of sartans in melanogenesis. The undoubted contribution of the world's first article on valsartan-induced cutaneous melanoma is its inclusion as the first serious side effect of this kind after administration of sartan. Acquired melanocytic nevi can be divided into two types: compound nevi with superficial or with a deep dermal component. It is clear that some cutaneous melanoma develop on the basis of existing or pre-existent melanocytic nevi and Navis-associated melanoma, characterized histopathologically by the presence of neural components within the melanoma tissue. Navis-associated melanoma, to date, without doubt, has the role of an antihypertensive therapy as a possible potential carcinogenic effect or a trigger. So, dysplastic nevi with valsartan therapy. Dysplastic nevi are an important factor associated with high risk of developing cutaneous melanoma. Therefore, if ARBs could be associated with cutaneous melanoma, then it is quite logical that systemic medication with an ARB can also associate with developing dysplastic nevi. It has been reported in literature of dysplastic nevi developed roughly 2.5 years after the onset of combined antihypertensive therapy, where the carcinogenesis might have been triggered by carcinogenic or the active substance itself. This could be the case with our patient, as I presented, who developed multiple dysplastic nevi after the therapy with valsartan and hydrochlorothiazide. Here we see a paper that's been published of a study which shows the exposure of ARBs and the high risk of cancers combined. So here the trials were shown where there's a greater risk when more than 3 years of exposure to daily dose has shown a significant increase in cancers. Hydrochlorothiazide therapy and melanoma. The antihypertensive agent hydrochlorothiazide has recently been reported and described in significant literature as possible inducers of melanoma or Navis-associated, most likely associated due to possible contamination of the batches with nitrosamines. According to the retrospective statistical analysis conducted and published by AAD, Washington, it can be said that the role of thiazide increases the risk of melanoma or skin cancer by 2-folds. The increase in publications and reports and studies showing the cancerous potent of thiazide has led to a marked decline in the use of such drugs, especially in Denmark. Here we see another study which suggests hydrochlorothiazide with melanoma, where the study analyzes more than 9,000 cases of melanoma, and we see the hydrochlorothiazide shows an increased risk of melanoma, as well as that with an even more elevated risk for lentigo maligna subtype. The Zantac lawsuit. In September 2019, the FDA had announced manufacturers to stop selling Zantac, ranitidine, in the United States because of the NDMA contamination can increase over time, alleging that Zantac had more than 26,000 times the level of NMDA the FDA had said safe for daily exposure. From the 3rd February, 2 weeks after the publication, the list of cancers that had been known to individuals with Zantac use can claim for has reduced from 10 to 5. What does this sudden reduction suggest? The risk of NDMA is causing the cancers from this list hasn't been changed. So what was the reason in taking this action? As of now, Zantac has redacted the articles, including the dates they published, after we have officialized this data. So therefore, in conclusion, here we present a patient with a possible valsartan nitrosamine-induced cutaneous melanoma, which later developed multiple dysplastic nevi after valsartan hydrochlorothiazide combination therapy. Taking into account the role of external factors as potential triggers of cutaneous melanoma, the action of ARBs in this setting could contribute to the clarification of some of the carcinogenic mechanism, which could lead to rethinking of the pathogenesis of skin cancer, particularly melanoma, its prevention and treatment. Latest studies reveal risk of cancer with long-term ARB use has public health implication. The role of nitrosamines as contaminants in these drugs may play a potential role in inducing neoplasia. This data has been reported to Bulgarian Drug Agency and EMA, but no checks have been available for contaminations of nitrosamines in drug batches and pharmaceutical firms till now. Thank you for your attention.